Like free medical advice or free legal advice, and I think we've all gotten a lot of that here at this conference. So I hope it continues and the dialogue does afterwards. We're going to be having a poolside reception this evening at 6 o'clock, a network reception upstairs. So you all are welcome to attend that. And I will go ahead and introduce our next presenter. Dr. Wade Mckenna is a leading advocate of autologous stem cell therapy and regenerative medicine, focusing on advancing the clinical benefits in orthopedics. He's board certified in orthopedic surgery. Dr. Mckenna is Chief Medical Officer and co-founder of Biologic Therapies, and a product development research company dedicated to the advancement of autologous adult stem cell therapy. His achievements include recent development of a Biomac bone marrow aspiration catheter, treating world-class athletes, and developing numerous surgical and non-surgical stem cell applications. Please give a warm welcome to Dr. Wade Mckenna.
I am not normally a podium speaker. I'm also not normally following a bunch of people with MD and PhD behind their names. So I'm pretty sure that at this point I'm just the surgeon, which I had one of my best friends point out this morning that very few orthopedic surgeons have ever referred to themselves as just a surgeon. We have a fairly significant reputation of not feeling that way about ourselves. But let's get on. What we're going to talk about is my clinical applications of bone marrow aspirate. We have, over the last 5 years, had a unique opportunity in a private orthopedic setting, in a very busy private practice, to be able to talk to patients about the clinical uses of bone marrow aspirate concentrate, starting with the very beginning of 8 years ago of just using PRP around knee scopes and using PPP to backfill our portals, and I could go through some of the clinical stuff with that with you, but just all we want to do is augment the clinical healing of some of these patients, and hopefully you get a little bit of taste of some of the clinical side of what we've been able to do over the last few years. What I'm going to do is leave it to the surgeon just to keep it simple, right? We just want to talk about who, what, when, why, and how, and we'll go through just kind of the clinical decision making, kind of what our experiences have been with bone marrow aspirate. My only goal today, this is a 3-hour college lecture we give, and I pretty much try to keep it down to the 30-40 minutes. So what I want to do is just provoke some clinical interest and see if there's anything I can add to your treatment arsenal that maybe you haven't thought about. The real problem for everyone in this audience is we're trying to treat problems which there's no other simple, easy answer. If this was a really easily adoptable technology and we could use it on the everyday things and watch the difference in the clinical results, then it's easy to adopt that use. When you're trying to use your product or your theory to help a patient where there's really nothing else has worked, we're only taking on the worst problems that exist. I mean, other than that, it's no big deal, right? So we're talking about OA, where right now in the US, really only palliative care is available, unless we're talking about arthroplasty, which is a significant intervention into a patient's life. We're talking about graft failure, as easy as ACL surgery. I mean, the ACL surgery, we all think that our grafts last forever. A really good 900 patient study showed that over the first 5 years, we can expect somewhere between 15 and 20% failure. In my personal basis, I would say that that's absolutely too much, that doesn't happen in my practice. That's not what the numbers say out there. So we all know that that never happens in my experience, right? So avascular necrosis, again, it's a problem that very difficult to treat. We're talking about core decompressions in the hip. We talk about grafting in the scaphoid. This still doesn't work. If there's one little thing we can do to help with avascular necrosis, and concentrated bone marrow aspirate has done that in my practice, again, we're talking about, and the whole premise of everything we've done is simple, elegant solutions to difficult problems. These are problems for which no other answer was out there. Is there anything I can do to kind of tilt the scale in our favor a little bit? Severe soft tissue injuries, and what I mean by makes your bad patients better is in orthopedics, you get an Achilles tendon rupture, rotator cuff tendon, some severe chronic tendinopathy, even extensor tears around the elbow, in a diabetic 80-year-old smoker on chronic immunosuppressive disease. That's a bad patient. because they're going to limit my surgical results. Not because of anything personal about them. They may be quite nice a person. But that's not the patient you want walking into your clinic saying, well, you know, I want 100% guarantee my rotator cuff's going to be better, I can lift my arm. I need some kind of biologic help with this patient, and that's kind of what we're hoping for with bone marrow aspirate concentrate. Non-union fractures. Most of the time, I'm fellowship trained in trauma, so most of the time when I see a non-union, it's not someone I've treated, obviously, right? It's someone that's come in 6 months out from treatment by someone else, and these are the patients, and I live and work in the country. Our hospital in Wise County is the only hospital for the 4 surrounding counties. It's a really nice facility. The problem is a lot of my patients travel for hour to 2 hours to see us, and most of them drive pickups just like their doctor. And these are people that are the walking wounded. A lot of these people walk in with a clavicle non-union for 6 months, and the only reason they haven't had it fixed is because the first doctor they saw told them that a plate on their clavicle might keep them from being able to shoot, cause pain with the gun barrel on it. So that's what we're kind of working with. Severe soft tissue injuries and chronic recalcitrant tendinitis. So next slide. The WHO. Some of this is way below the audience in here, and we'll try to skip through this pretty quick. It's just so many of the articles out there when you're talking to, especially even the physician-to-physician peer part, it's hard to get everyone to understand we're talking about the same thing most of the time. Next slide. What I'm going to do is just call it bone marrow aspirate concentrate or BMAC or MSCs. So everyone understands that really the basis of why we're trying to use bone marrow is the pluripotential nature of the cell. It can become most of the soft tissues around the body, even the ones we don't have listed here. Now there's some new evidence as far as neurologic healing. The pluripotential nature of the cell is an easy argument to make. Most people understand that. What's failed to transfer over into a lot of the mainstream literature as of yet is the potent immunosuppressive and anti-inflammatory effects, and then the secretion of the trophic factors. The growth factors in what we do is everything. The reason that bone marrow aspirate concentrates kind of became, well, first of all, I'm in the US, so the reason that that's became my solution of choice is because when we spin and concentrate the cells, I'm getting a concentrated growth factor solution too, and that's the media for which I'm transferring those cells. Next slide. Differentiation of mesenchymal cells. I'm not going to spend a lot of time on that. I think everyone in this audience has a handle on that. Let's go next slide. The what do they do? So we talk about differentiation to other tissues, but really chondrogenesis is the goal of treatment of OA. We don't want a palliative care. We don't want an anti-inflammatory. We don't want to, actually with steroids and most of the anti-inflammatory, we're actually causing a catabolic effect and probably increasing the amount of long-term disease the patient has for a small palliative relief, and that's not my goal in treating the disease. The goal of using MSCs is to promote chondrogenesis. What we're trying to do is provide some gap between palliative treatment of the disease and a resurfacing arthroplasty. Next slide. A complex process, and I'm not going to go through all this. Obviously, SOX9, some of the transcription factors. We understand how collagen forms. Basically, the reason for a general science slide and going through all the chondrogenic pathways and taking everyone through mitogen activation, not nitrogen activation, and the protein kinases and SMADs, the only reason to do all that is to illustrate that I don't need to know all that. The cell knows all that already. Go next slide. What I'm doing is we're defined degenerative joint disease. It's just pain, joint stiffness. Go next slide. The key is that 80% of everyone in this audience over the age of 60 is going to suffer from some form of joint disease. I went to college to play ball, promptly got hurt, and then became a doctor. But still suffer from the fact that I traded my body a little bit for an education. 27 million Americans out there feel the same way as I do. In 2010, over $15 billion was provided for pharmaceutical arthritis medicines. So when they talk about the money being spent on what we do, we're fighting a $15 billion market out there too. So, next slide. Degenerative joint disease. Right now, just the standard of care for anyone not in the orthopedic world, NSAIDs, viscosupplementation, hyaluronic acid products, bracing, unloader bracing, give people some stability through stair steps, activities of daily living. decrease the swelling, decrease pain, and try to keep, and again, most of what I do is to try to keep or return a functional level to the patient. That needs to be the real driving goal of everything we try to do. Arthroscopy. Arthroscopy, there's a great article written to say that arthroscopy doesn't help arthritis. The problem is that I've never given a patient the diagnosis of arthritis and a CPT code of an arthroscopy. What we're treating is osteochondral loose bodies, debris, meniscal tears, joint chondromalacial changes, grade 3 or 4 changes, cartilaginous flaps, things that cause mechanical symptoms and pain. Mechanical symptoms and pain can be treated by arthroscopy, and a lot of times a loose body removal makes a dramatic difference in a patient's life when they can't get up and down out of a chair. And not sticking a scope in that patient and pulling out a 2 centimeter loose body that's been there for 5 years is kind of silly. I mean, it's a very easy, limited intervention to make a dramatic difference in some of these people's lives. Autologous chondrocyte implantation, ACI surgery. There's only 1,500 ACI surgeries done a year in this country. It's a great idea. It's extremely costly. It's 2 or 3 different interventions in the OR. Resurfacing and arthroplasty, total joint surgery. We actually have a joint that I worked extensively on with Consensus. I'm a firm believer, total joint surgery is what made me want to be an orthopedic surgeon. Someone replaced my grandmother's knees when I was 14 years old, and she went from waiting for God to call her home to selling her house, buying a motorhome, and traveling all over the country to see her friends. So that's what made, I just remember thinking, man, if you got to work, what a great way to make a living. Next slide. What do we know about cartilage repair? Is there any evidence to show that what we do makes a difference? A couple human use studies. The study in Malaysia, a little different than what we do. He was using peripheral blood. Certainly the opportunity to do second look arthroscopy, certainly there are some limitations with the study, 10 patients. We all know microfracture, and this is the one point in this, is microfracture is the standard of care for an osteochondral lesion in the knee, and it doesn't work. Next slide. Equine study, you don't have to be one of you guys to see the difference in the fact that if you look at the osteochondral surface over this created deficit in a non-BMA patient compared to the BMA patient in the equine studies, there's a significant difference in the articular and chondrocyte proliferation and growth. Next slide. Rabbit studies, big osteochondral defects, significant difference in the healing. And the part from the clinical application of this for me and what we've seen in our patients is exactly this. As early as 2 weeks, the chondrogenesis had begun and proliferated big chondrocytes. At 24 weeks, there was dramatic overlying articular cartilage. Next study. It's one of our patients. We'll get into some of what we've done. Go ahead, next film. 50-ish guy, been told by 3 other guys before he got to me that because he was bone on bone on the medial joint space, he needed a new knee. This patient wasn't ready for the dramatic intervention in his life of a new knee. Asked me if arthroscopy stood any chance of making him better at all. We had a discussion about the use of bone marrow aspirate concentrate, the fact that maybe we can tilt the scales in our favor a little bit. On MRI, he had dramatic osteochondral fragments, debris, cartilage tears. An easy argument to make as far as the arthroscopy, especially if we can help augment his repair. This is him at 6 months, active, healthy. There's literally a return of the articular surface. So on standing weight-bearing film, again, it's not dramatic, but it's just only subtle differences. Again, this guy didn't go to hurting all the time and decreased range of motion and decreased function in a period of a day. It happened over a long period of time. All I need to get him is a little bit ways back down the pathway and see if I can keep him active for a little longer. Next slide. This MRI is in that same patient. You can see the osteochondral changes underneath the patella. Next slide. Fairly dramatic trochlear groove changes, moth-eaten appearance on the MRI. Fairly dramatic difference. 6 months. Next slide. One of my favorite patients, just because the result was so dramatic. This is a lady who had about a 20-degree standing varus, and I wish I'd shot these on where it could show more of the defining abnormalities, because if you look, the tibia is literally translated laterally as the femur collapses, big osteochondral spurs, dramatic changes in the subchondral surface, about a pretty significant pseudolaxity on physical examination, in shape, lean, active, doctor's wife from another state that had the unfortunate experience of riding in an airplane next to my mother, and who came to see me based on my mother's referral. I swear to God. This is her result, and literally this is her result at the first 3 months. So to change the articular surface and rebuild chondral growth, and actually change a patient's pseudolaxity, it literally changed the anatomic alignment of her joint, and this was after an arthroscopy, microfracture, and bone marrow aspirate concentrate. Next slide. This is that same patient. This is the MRI, because once I saw the standing films, I was in a little bit of disbelief. 5 months, and the articular surface pre-op, articular surface post-op. Literally, the only decent articular cartilage this lady has, and this is as the lowly orthopedic surgeon, I think God all the time that He gives me two, so I can compare it to the other side. In articular cartilage films, we compare it to the non-articular surface, right? So her non-articular surface, or posterior part of the condyle, pretty significant articular cartilage covering, articular weight-bearing surface, fairly destructive, and this is at 5 months. Next slide. So osteogenesis, way easier than chondrogenesis as far as the reports in the literature. Spine, really every spine surgeon that wants to get their fusions to heal needs to be using bone marrow aspirate concentrate around your graft. There's the literature, and I wanted to put a bunch of the studies up here, but literally, I'm going to show one, but the literature is so replete with studies where you can take a dead, worst bone graft known to man in a study and make it equivalent to iliac crest graft. That doesn't happen. Iliac crest bone graft, rib autograft, those are the gold standards. If you can take a dead graft or any synthetic and get your results similar to, equal, or better than iliac crest autograft, you've done something. And you need to look at what else is out there just to help aid your results. You're not doing anything that dramatically different. Angiogenesis, a unique and something we don't talk about or study, but I think most of us know you have to have blood supply to heal bone, you have to have blood supply to grow cartilage. The angiogenic growth potential of the mesenchymal cell is one of those, oh, by the way, findings when you do a study, right? You look at the results and go, oh man, look, now some of the new studies on compartment syndrome, cardiac ischemia, some of the things you guys have already presented. What you're doing is not only repopulating a dead cellular collagen matrix, you're bringing the tissue viability back. And some of that is the angiogenic growth factors. And angiogenesis is crucial to the survival of muscle, tendon, ligament, bone, and cartilage, right? With no blood supply, it does not exist. Next slide. Everyone understands that we are not, and this is how this is one of the easiest points to make as just a clinician. If I'm going to change the normal pathophysiology of a human body and I have to change how something works in nature, I might have a problem. That might not be how it works. We're not changing how the human body heals in nature. This is how the human body heals. The normal stages of growth and attractive to the angiogenic growth factor from the HSCs, the MSCs causing the attraction of more cells. This is bone growth cycle. I'm not doing anything to limit that. I'm not doing anything to change it. We're augmenting tissue. Next slide. Case study, not ours. It's a published study out of Hiroshima. A 28-year-old male, and this guy had a long and desperate attempt in this first visit to the ER. Open tibia fracture, bad compartment syndromes, open fasciotomies. Over the next 6 months, non-healing of a fracture, was never out of his frame, lost half of his foot, a couple toes, big skin graft surgery that had trouble healing. Next slide. Well, all they did, and they obviously didn't have the access to some of the technology, I guess, at this time that we do now as far as concentration of the cellular volume. They used a harvest and separation of 700 cc's of bone marrow, got 50 milliliters of what they called bone mononuclear cells, and all they did is inject all this around the gastroc, around the fracture. No carrier, no media, no secondary grafting of the site. Next slide. I'm going to go right to the clinical. So next one. This is the best one for me. I love this slide. This is the arteriogram of this lower extremity prior to the injection of this cellular volume around the fracture site. The difference at 4 weeks in the collateral arterial supply shows something changed. You had dead acellular muscle. You're losing the angiogenic factor of the blood supply to the lower extremity. And at 4 weeks, with injection of the growth factors concentrated from that blood separation, and with that volume of mesenchymal stem cells, to be able to get collateral circulation, non-union, starting to union, full weight bearing at 6 months, in a patient that had no other interventions, grafting, mobilization of the frame, dynamization of the frame, all the things that we would do in this country didn't happen. Basically, this was a patient who they had talked to about amputation of the lower extremity, and with a fairly novel approach at the time, saved his leg. Next slide. Spinal fusion literature. I think this is the best documentation of osteogenesis in the human body. There's almost no spinal fusions in this country. Obviously, is one of the leading costly surgeries performed that has maybe not necessarily the most glowing outcomes if you base it on anything other than an X-ray, but certainly the patient that deserves anything we can do from a medical standpoint to help aid that patient get through this surgery with a better result, we probably need to look at. Next slide. One of the best studies, and this is out of Delaware, so every orthopedic surgeon that trained when I did understands that DuPont was the mecca of pediatric orthopedics. And rib autograft, when you're doing scoliosis surgery and you have the opportunity to resect that rib hump and you can take all that rib and melt it up as your graft, you almost think you can watch the spine fuse. It's the best graft. All they did is take an osteoconductive matrix, add bone marrow aspirate concentrate on one side, the rib autograft on the other side. The fusion rate was the same. The morbidity, obviously, of rib harvest compared to a bone marrow harvest is dramatically different. And the healing time was actually accelerated with the concentrated bone marrow compared to the rib autograft. Next slide. So basically, we're saying that BMA can make your graft equal to rib autograft. Next slide. This is the guy, competitive shooter, only came to me because it was starting to bother him too much to shoot a gun and he couldn't climb up in his deer stand. 6-month fracture, 50-year-old smoker. Next slide. Intraoperative film, obviously I know it's a non-indicated procedure because you really can't get that much compression across the non-union with the Rockwood pen. Again, I explained to this patient that compression plating was the standard. He doesn't want to plate on the front of his clavicle because it hurts. His clavicle is real subcutaneous in this guy, and he's a big man. Next slide. This was the slide my PA did a 30-degree caudal and 30-degree cephalad x-rays of the collarbone at 5 weeks after surgery. I'm walking out in the hallway, my PA goes, "What's this?" And I looked at it and said, "Well, that's bone." What I'd never seen is the heterotopic. All we used a graft-on matrix that I soaked in the bone marrow aspirate concentrate, and then wrapped that not only within the bone before I put my pin in, so you can see kind of the thicker cortical and intercalcis bone, but now you got this big, almost hypertrophic. So we had an oligotrophic non-union in 6 months in an adult, and now we have a hypertrophic, almost bone growth right around what was a previous non-union site. And the guy still hasn't let me take out his nail. He has a little, these come with a little washer kind of behind the clavicle where you have to make an incision to take them out. It doesn't bother him. So, next slide. So this is the what. So we talked about the pluripotential nature of the cells. We talked about, now let's go to the immunosuppressive effects. Next slide. Good skin graft survival study that's out there. is actually sponsored by someone that actually mentioned Prochymal earlier in the day yesterday. I think it was Dr. Riordan. Basically, it was funded by them. But what they did is they showed a significant difference in the lymphocyte T-cell control by just adding mesenchymal stem cells with allogenic skin grafts. We're able to save some of those in a baboon study, and that's none of the control group survived. The experimental encephalitis model for autoimmune encephalitis in the murine model is the animal model for MS. And in the patients treated early with the MSCs, striking amelioration of the disease, and that's their words from the article, not mine. And that's looking at their study, they believe it to be modified just by T-cell anergy. It's been talked about already, the severe steroid refractory graft-versus-host disease, 80% fatal in the children that have that. So the patients get told they're going to die twice. I don't think that's fair. Bone marrow transplant patient developing graft-versus-host disease, there's no real hope for some of those patients, and especially if they're stage 3. And treated successfully, 6 out of the 8 patients in the initial study survived. And there wasn't anything else that could have done that with all the other drugs, steroids, and even the chemotherapeutic drugs that they administer to some of these kids. Next slide. For me, the BMA is not just about the MSCs. So we spent all this time talking about the MSCs because it's way more interesting to talk about the potential of the MSCs and the trophic effect of the MSCs. MSCs, even in a volume of plasma, or even in a solution or whatever the carrier media is, do promote the secretion and formation of the trophic factors that we need. Well, what about if we just give ourselves an extra little concentration of the trophic factor we need? With the spinning down, one of the differences in bone marrow, and I'm amazed that from a clinical standpoint, obviously my peers, bone marrow is 97% whole blood. When we spin down bone marrow, we're getting PRP. We get that platelet-rich plasma. We get 15 times baseline concentrations of VEGF, FGF, transforming growth factor beta. These are my building blocks for the soft tissue and the activation of the cellular volume and to be able to use the MSCs. So I don't have to settle for one or the other with bone marrow. And the trophic factors are crucial in what we do. There's a lot of good PRP studies that made a difference in soft tissue healing and chronic tendonitis. I don't have to just settle for an acellular matrix to do that with. So we have all the advantages of PRP with added advantages of MSCs. Concentrated growth factors. So I tell people all the time, you can get, BMAC is concentrated growth factors and concentration ESC, but PRP is not. So when doctors try to talk about PRP as stem cells. You get PRP with bone marrow aspirate concentrate. You do not get bone marrow aspirate concentrate with whole blood. Next slide. So these are the brief. I'm not even going to spend time. Everyone understands what we're talking about as far as the growth factors, the fibroblastic growth factor. I didn't separate all the transferrin growth factors out. I just added the S for the betas. The key is that the bone marrow aspirate concentrate has that advantage. Okay, next slide. When? So the when do I use bone marrow in our practice? Obviously, long bone fractures, small joint fusions. Anytime I need bone to heal that doesn't want to heal, or cross a joint space where it doesn't want to cross a joint space. Anytime you can avoid pseudoarthrosis in a big surgery, I'm in. Vascular repair, angiogenesis for compartment syndrome. Everyone here, I don't treat cardiac wall ischemia or chronic angina. You're welcome. I'll leave that to the smart guys. Sports medicine, there we go, my home. Surgical and non-surgical, rotator cuff tendinopathy. Not a lot of room for the rotator cuff and a lot of shoulders. As the cuff desiccates, the desiccation, the drying out of adult tissue, there's just not much room for it sometimes in a tight space. In my world, it's easy to use the analogy of an old rope and a pulley. Everyone knows that when you have a brand new rope, even if the pulley's old and tight, the rope still fits and does pretty well. That rope dries out in your barn for 10 years, starts to fray out, it's at risk of rupture. It pops through that pulley every time. It gets a little bit harder to use, gets a little bit stiffer. That drying out of that rope is desiccation. That happens in the human body. Average age of rotator cuffs is late 40s or mid 50s. It is an eventuality for a lot of us that don't have a lot of lateral or medial arch room in your shoulder. And as that tendon gets a little older and dries out, it takes up more room, not less. There's no way to repopulate that acellular desiccated matrix. It's a great carrier. We don't need a synthetic. We have it there. It's just very acellular. It's a little dried out. It doesn't have a healthy tissue growth. Injection of bone marrow aspirate concentrate in that tendon in a non-surgical fashion makes a dramatic difference. Achilles tendonitis, lateral epicondylitis, those are the things that have actually been written. Chronic tendinopathies, ligament and soft tissue reconstructions. Talk a little bit about this in a sec. Chondrogenesis in the joints and non-unions in wound care. Next slide. Why bone marrow? Because of the MSCs, because of the growth factors, and because of the hemopoietic cells. And when I put this on the slide, I have to credit Brian Barnes with this because he came up with this, and I loved it. Basically, when we talk about bone marrow aspirate concentrate, this is how we won World War II. We didn't start on one front and try to move across. It got to the point where we had to make use, because we couldn't do it. We weren't winning the war. We had to be able to drop ship troops where they were needed. The use of technology with airplanes and troop movement and parachutes is how we won. We attacked them where they were needed most. And that's kind of how I think about bone marrow. I'm addressing the site of injury. And I think that the ability to use, go to the next slide. The ability to be able to use this in our practice has been basically what it comes down for us is what else you got that works. I mean, these are problems then in your practice that you're going to have to see and address. And if you are looking for, you know, my grandma would say, the any port in a storm, these are the things that if there's anything I can do to help my patient, I need to start focusing on that. This is what I talk about when we talked about ligamentous reconstructions. Great study in the use of growth factors on ACL grafts, and everyone that's been in a group practice will understand this. The control of the non-use of the growth factor, all they did is they took their grafts, everyone was using allograft, some people were using different versions of the allograft, and they soaked it in PRP during the reconstruction. Their control was one of the guys in the group who didn't believe in PRP and didn't use it on any of his, and the treatment group was the other two guys who tried it. So anyone that's ever been in a group practice understands that probably about how it's going to work. The guy that didn't use the PRP, when you look at the homogeneity of the graft, return to a homogeneity of the graft, which would indicate healing, 379 days in the non-treated patients, 179 days and 369, excuse me, in the patients that were treated. That's a 50% reduction in the time it took to make an ACL graft look healthy on MRI. There's also a good study out there to show that returning health on the MRI does correlate with a healthy graft, so I'm not using a measure that doesn't matter. But homogeneity on MRI, return to your graft, is everything. I mean, all you want to do is make the patient heal, less risk of re-rupture, right? Compartment syndrome. We looked at a significant case study earlier. Rotator cuff injuries, and this is the hard one. You know, the rotator cuff and the immunocompromised 70-year-old that can't raise their arm, that person needs forward elevation of their arm as much as anybody. You know, the person that has to do this to get their arm up, it's a significant limitation in daily function. Spine fusions, again, the best use. What we've been doing with avascular head and neck was almost an accident. We used to do a lot of core decompressions where I was a fellow in Tampa. I developed a true disdain for a surgery that's that complicated and doesn't seem to work that well. You're providing this acellular matrix up into the head of the femur, and by the time we saw most of the ones that did really well were the ones we caught really early. Most of the ones that didn't really do well were the ones that were really symptomatic and were having real problems. What we've done is take that same application of core decompression, make a little bit of a mental jump, and when I have the unhealthy femoral neck fracture, and I want to restore or try to slide the scale in my favor of getting that fracture to heal and letting the head not go on to avascular necrosis and collapse, which is the biggest complication of a femoral neck fracture. Once we drill the screw up in there on a cannulated screw, pull that screw back, squirt concentrated bone marrow aspirate up into the screw with using PPP as a biologic plug of that, reseat those screws. Over the last 4 years, almost 20 femoral neck fractures that probably I could have made a pretty decent argument for hemiarthroplasty in had they been healthier, who I planned maybe on having to resort to hemiarthroplasty later. I haven't had a failure yet. And it doesn't mean that it's all relative to the growth factors or the BMA. Certainly, I feel very fortunate that the patient's healed. I feel very fortunate that they were able to avoid hemiarthroplasty. But I know we've tilted things in our favor because we've already taken a surgery that's described in the literature as core decompression and its goal, and just modified it a little bit with the biologics to help aid us in getting someone to heal. Okay, next slide. Age-related misconceptions. Several good studies talking about the chondrogenic potential of those cells is very similar in the elderly to the younger donor. And I actually changed it on the way I had it on the slide. It showed that the cells, and it said extremely old, I think, in the paper. So I changed that extremely old to elderly. I think they're basically everyone in the study was octogenarians. Decent fracture study talking about circulating plastic mesenchymal stem cells, actually just showing that the body does, and the only reason I included this is I want everyone to understand, I really do think this is how we already heal, and those cells are secreted in the peripheral circulation in the elderly. 22% of the hip fracture patients showed circulating mesenchymal stem cells within the first day and a half after their fracture. So they're there, and they're still used in the modulation and treatment of healing as we get older too. Next page, sorry. Okay, the reason this is called the what is because my little kid, I have an 11-year-old and a 15-year-old, and if anyone listens to the radio right now, that thrift shop song is killing me. And then the whole first part of it is what, so now we have the what of stem cells because we already had what. So now we have the what. So what proof do we have that it works? What proof do we have that microfracture surgery works? And this is what promoted all my use in BMA. There's a review article out. 28 published studies exist on microfracture surgery. It's a standard of care. If you like baseball or football and you read the sports section, every week there's someone that had microfracture arthroscopy and microfracture of their knee. It's not a great surgery. Matter of fact, the biggest review article written on microfracture surgery, what was their conclusion? Further well-designed studies are needed to determine the long-term efficacy of microfracture surgery and define its specific clinical indications. This is the most common arthroscopic surgery performed in the United States. In 07, out of the 400,000 chondral procedures performed in the U.S., 200,000 of them were microfractures. So we're performing a study on a daily basis that there's really no clinical proof to show that it makes a dramatic difference for anybody. It's an ameliorating palliative treatment. Next slide. So, well, there you go. So 400,000 procedures, 200 are debridements and microfractures, about 1,500 ACIs. We do a lot of OATs for big articular lesions in young people. I like that surgery. I think it makes a difference. I also think that bone marrow aspirate concentrate aids the healing of my graft and my plug. The literature is shifting towards heavier use of biologics. If you pull up in 1998 and search every paper using MSCs for that year, 271 papers. This is from a review article on osteoarthritis. In 07, there were 1,700 papers with that same search. Next slide. This is from our radiologist, and he's the only neuro-fellowshipped trained radiologist specializing in open MRI technology that's musculoskeletal fellowship trained. I think I said that right. He'd be really proud of me. He actually ended up being a significant referral base for us because when he was reading some of these pre and posts, he literally called me and said, "What did you do?" He said, "There's cartilage. This knee looks like the before, and I don't know how to do that." And he said, "I've never seen grade 4. He goes, "We need to add a grade 4S because you changed the subchondral health of the bone." So this is go to the next slide. What he said is his first reaction to the BMA cases was that the cartilage chondrolateral process was going the wrong way. Next slide. So he's an advocate. I've actually taken care of some of his family members now from Canada, even the smallest of improvements, and that's exactly right. If you can do anything to, and the analogy I use all the time, again, is simple, easy analogies is a car tire. If you're driving and your tire's out of line a little bit, it wears out a lot faster. Arthroscopy is just about putting the tire back in line, getting rid of the debris. There's never been a way to help put more tread on the tire. And while we may not be putting more tread on the tire, we're putting air in it, and we're aligning it right, and we should be making what you have last longer, run better, and maybe hurt less has been the goal of the treatment. Next slide. So the conclusion, BMA was driven by the fact that I had a lot of problems in the practice that didn't seem like there was a lot of really well-published answers for. My original thoughts with the bone marrow aspirate when we started using this with microfracture patients about 5 years ago is that if microfracture makes a difference at all, and the results for the first 20 months, 24 months, 2 years in microfracture surgeries are pretty good. It does make a clinical difference for the patient. But if a couple drops of concentrated bone marrow, and that's how we judge in surgery if it's successful. When you're looking at it and you poke your holes in the bone, you're like, yeah, I got a little bit of fat droplet in the knee. If that makes a difference at all, what does the potential concentrated volume of over 100 cc's of bone marrow do for that same patient? It's not going to make them worse. If a couple drops makes any difference, then what we're doing should make a bigger difference. Next slide. So this is the catheter, basically because bone marrow is a big, scary procedure. There's not a lot of general orthopedists that feel real comfortable just sticking a catheter in the iliac crest. There wasn't really a good way to do long bone harvests. Next slide. What we wanted to do is, and what we do, again, we don't have access to 20 or 30 million cultured cells. So my job is to try to maintain the cell volume or cell count of that bone marrow in however way I can. And that comes to doing less traumatic harvests, less clotting at the entry site, less activation of the plasma, less cell wall lysis. Those are the goals of the harvest because I want as many cells as I'm going to get. I don't want to start out with a harvest that's so traumatic that it limits my cell volume when we go to look at it. Rounded spherical holes, more cannulations. You can tell I'm an oil-filled brat because we talk about fracking the well. If you've got a straw and you want to drink water, you don't drink from a running faucet. You drink from a cup. And that's what we're doing with the STEMSOs with the harvest. What I'm trying to do is prevent that clotting that you get from this big dramatic draws with activation of the cells by putting this little plunger in. It literally fracks that zone. If you're from Texas, you know exactly what I'm talking about. You're going to provide, you're drawing from the lipid pool after that. So when you put your syringe on there and start to pull, you get better, easier flow, less turbidity. It's all about the fluid mechanics, right? You get some real turbid flow, you get increase in clotting, and our cell count's going to drop. Next slide. I think, is that it? Is that it? Okay, so this is the how. I'm going to show two real, like, 1-minute videos, I think, if we can get that. This is an ACL patient, so a lot of times we just do it from the anterior wall at the face of the tibia. Most of my draws I still try to do from iliac crest. I've done my mom. She has bad OA, probably not health-wise a great candidate for total knee arthroplasty. Done iliac crest draws from both sides, injected it into her knee at the time of an arthroscopy for a big meniscal flap. If she was here, she would tell you how wonderful she's doing. We have about 1,500 patients, so this isn't a clinical review of 5 people that I've done, and they seemed to do better. We've done New York knee scales on these patients. There's a significant difference in the swelling. And where a clinician will see the biggest difference is that first 2 to 3 weeks. I do my own, I'm in a small town. I mean, I'm a really busy practice, but it's me and a PA now. And I see all my own patients for post-op dressing change when I do bone marrow, because where you're going to see the biggest difference clinically, the one that convinces me to do this is the patient at 2 weeks when you do the suture removal. Is there any sound on that? Well, I look amazingly fast. Pull it back and hit play and see if it loads faster. If you're going to have a surgeon, you might at least show something cool, right? If you're going to have the clinical guy. Okay. I think most of our videos we use QuickTime. They have videos at the booth next door. Basically, and for me, the key is I'll put my hand over the iliac crest to move that skin. Some of the little caveats or little pearls of doing this procedure, if you just make a poke hole right over the crest and drive a skin through it, you get a little bit of synovial tracking sometimes. It hurts more when they put a belt on or pants. If you move the skin over the iliac crest is really mobile in most of us in America. You can move and mobilize that skin just by taking your fingers and pushing it over the inner table. So before you make that little poke hole, and again, a little bit of a fanatic about making a little bit of poke hole in the skin, because that little bit of skin activates cells and you can drop your cell count. Poking it through the skin, getting a little bit of a skin plug within your cannula lowers your cell count. So again, we want to do anything we can do to make our cell counts higher, make a little poke hole through the skin, but then it's almost like Z-tracking a shot, because when you pull that skin over and make your poke hole, when you let go, that poke hole is 3-4 centimeters below the iliac crest. It doesn't hurt. They don't get that pain right over the crest. Matter of fact, because of the shape of the catheter, and this is what really provoked the development of the catheter, when you take a big jam sheety, which is what all of us use, and you take a big jam sheety and brutane and jam it through an iliac crest, or especially through cortical bone of a long bone, when you look at that microscopically, you got this big microfracturing around that portal, and you get a subperiosteal hematoma. It hurts and they get infected. Subperiosteal hematoma can be there on MR for 3 to 6 months. When you make a round hole without all that microfracturing and splintering, we've been able to put pressure, I can tap on that at 2 or 3 days and patients really aren't tender. When you do it with the jam sheety, which is what I did for the first few years, it's brutal. You can't do it in the in-office setting, surely. I've never been able to put a jam sheety through someone's tibia under local. We do this under local in the office all the time for their follow-up injections. A little bit of local skin wheel in the subperiosteal plane, mobilize the skin a little bit with your finger when you pull it over, put your fingers on the lateral head of the fibula, pull the medial face over, put the drill right on the bone, drive it right in while you're talking to the patient. And when you do the plunger, this is easily accomplished in an in-office setting with the point of service delivery. I wasn't ever able to do that with the jam sheety, and it hurt forever. Even with the iliac crest incisions, it hurt. And with a little round drill bit making a round hole, to not liberate all that blood with little microfracturing that leaks underneath the periosteal sleeve of the bone is dramatic. So hopefully you get a chance to see. I mean, literally this draw takes 3 minutes. I mean, from the time you make your poke hole, put in your trocar, plunger down there to frac your area, hook 30 cc, and again, you'll see I don't use 90 cc syringe with a lock on it. I think it's too traumatic. I want a slow, easy, less turbid flow. I'll use 3 to 4 30 cc syringes. Now, there's no hurry. I don't pull it up to the top and clamp it with the clamp. I like to decrease the turbidity of my flow because some of the cell count studies we did showed it made a pretty dramatic difference. So I can't culture it, so I have to do little things that help my cell count. I think that's it. No, I literally use a plunger that fits about 1.5 centimeters below the tip of your trocar. So when you take the trocar point out, you're left with this big fenestrated sleeve. The plunger fits right down that sleeve. What it does, especially in the cancellous bone, it just liberates a little bit of an area for you for the fluid to collect. Everyone understands that the iliac crest does not have a volume of 180 cc's, right? We do 180 cc draws all the time. What we're doing is retrograde blood flow washing out encrypted cells. Those encrypted cells are closer to the top of the crest. This little 45 cannula fits right along the top of the iliac crest, and I can draw 180 cc's out of there fairly easily. I've done it proximal humerus. The original catheter design, this again, a lot of this stuff comes from, I was a trauma surgeon in Tampa, and when you're trying to resuscitate a kid, interosseous fluid volume is way easier to deliver than an IV and some kid in shock. We'd end up with an 18-gauge needle going through proximal humerus or a tibia, hooking up a liter of fluids. You start to resuscitate the patient a little bit because interosseous fluid goes really fast in the intravascular system, and you could save a kid's life with an 18-gauge needle. The EZ-IO has made a really good attempt at that, and we worked a lot with them. The problem is it spins off the hub. There's not a lot of quality control measures, And any nurse that you talk to, and when you're resuscitating a patient in shock, you got to get some blood, right? So every nurse, you got to get some blood because you need to know, I mean, you want to know where that patient is status-wise in shock. You can't really draw out of the EZ-IO. There's not really a lot of retrograde flow. It clots really easily. So the purpose of this from an emergency resuscitation standpoint is you can also draw that first 30 cc's of blood that you need to send off to the lab so you know where your patient metabolically stands. So proximal humerus is easy. The only reason I don't teach people proximal humerus very often because I don't want them nabbing the inferior axillary branch of that nerve. It follows about 3 centimeters below the anterior tip of the acromion. When you look at some of the literature out there, that's where everyone wants to put that needle. I've seen some pretty significant anterior deltoid atrophy on a patient that's had a trocar stuck in their proximal humerus. So I don't talk about that much, but yes, in surgery I'll do it. I'll stick it down the greater trochanter and pull it out there if I see some big chondral defect at the time of a scope. But I'll go higher up in the subacromial space and pop the catheter through while I'm looking at it with the scope. Sorry.
Thanks. 2 comments and 2 questions. I really enjoyed that talk. Thank you. Obviously, one comment, both moms and grandma are very inspirational. I didn't mention in my talk, but it was because of a national news report on adipose stem cells with my mom in 2001 that got us started on this field. So just a personal note.
Yeah, we were raised right.
That was cool. The other comment for the audience, I'm really sorry I wasn't here for the panel. I was stuck at 2 drawbridges. In between 2 drawbridges and traffic. I've never had the experience of not showing up for something like this before, but I apologize. So I'll try to introduce some controversy now, or at least a question. I wondered what your thoughts are on allostem. You didn't refer to that in particular. I'm curious how you think that would compare, that is the ASCs in the context of demineralized bone matrix vis-a-vis some of what you've presented, if you've had a chance to look at that. And secondly, maybe the controversial or interesting part, what about the fact that what you're able to do now is able to be done, as I understood it from Marianne's talk and others, you know, just in general knowledge, because bone marrow is a carve-out. If it wasn't for the fact that bone marrow was effectively grandfathered in, none of what you described would have been able to happen.
I agree. I think that what's prompted a lot of the work we're doing is because I can do it, right?
Exactly.
So I think some access to cultured cells would make a fairly dramatic difference.
Absolutely. So. Any experience with the allostem product?
I have not had any. I use a lot of amniotic products for adhesional problems around tendon grafts and things like that because I found it to be great from the growth factor standpoint and for preventing some of the adhesions that you get that you end up having to have a patient that maybe doesn't get the same result that they would have if they didn't scar in so much. So I've been a fan of that. But I've not had much access. And again, from a hospital standpoint, I can usually find a way to help the hospital get paid for the bone marrow kit. And it's extremely difficult to get paid for some of the other biologics doing what we do.
Have you had any opportunity to look at your outcomes vis-a-vis the complement of CD34 or any other kind of cell description within your BMAC?
Only with the stuff that Arteriosite did in the very beginning. With the original cell counts that they published, all those came from Decatur, Texas, where we were doing the draws while they were in the room with me.
Thanks.
Thank you, Don. All right, that concludes the general session for today. We have a poolside reception that begins at 6 o'clock. Please come casual if you feel don't want to wear a suit and tie outside in Florida heat. That totally makes sense to me. So please join us at 6 o'clock. We begin tomorrow morning at 8 o'clock, and breakfast begins at 7 o'clock. So breakfast goes from 7 to 8, and then the general sessions begin. And our first presenter tomorrow will be Dr. Adam Katz. And his presentation will be Waste Not, Want Not, 16 years of fat thinking, and we're really looking forward to hearing from him as well. So thank you.